We continue our discussion on glomerular diseases. Again, I have some questions for you. Stop the video to read the questions. This question for you. Mark the answer in your paper. The topic of discussion is membranoproliferative glomerulonephritis. So first of all, we learn the basic concept about MPGN. MPGN. Membranoproliferative glomerulonephritis. Well, it's a group of diseases, so-called MPGN I told you. And this is a immune-mediated diseases. But there are some exceptions are there about which I'll be talking to you little later. And these MPGN, they are characterized by glomerular basement membrane thickening and proliferative changes also. Okay, and this we can see in light microscopy. There are three types. That means we have type 1, type 2 and type 3 MPG. And each one is primary or secondary. Primary is idiopathic. Secondary, there is some reason, any disease or something, some reason is there. Reason is there for the cause of the problem. Primary forms of all, they tend to affect the children and young adults, usually in the age group of 8 to 30. It is very important to know this. What's the reason? Why this is so important? We also know very well that in children, the commonest cause of nephrotic syndrome is minimal change disease. And that primarily tend to involve 2 to 8 years. And this involved 8 to 30 years. That's one point so important to talk about. Primary account for about 10% cases of nephrotic syndrome in children. Remember, the commonest cause of nephrotic syndrome in children is minimal change. Secondary form tend to affect more of adults. The children, I told you, maybe in the range of 8 years or younger people, and these are usually about 30 years. The secondary form, they tend to occur to the, you can say, middle-aged people tend to get it affected. Men and women are equally. There's no difference in male, female. Complement level is reduced. This is the most important thing to be remembered till now. Why is it so? I presume that you have seen glomerular disease part 1, part 2, part 3. Okay, and I discussed 3 different diseases in those. In all the previous 3, the complement level was normal. This is the only one in the glomerular disease discussed so far where the complement level is reduced. That means if you are getting a case of nephrotic syndrome with reduced complement, you should always keep in mind about MPGN. Okay, this is a very important point to remember. Now let's learn the basic pathology of this disease. First we learn again revise the normal histology. The normal histology is like this. This is the epithelial cell. Here is the foot process, epithelial cell, foot process, glomerular basement membrane, and this is the capillary endothelium. This is the capillary wall with pores. This is the capillary lumen where the blood is flowing. Here the supporting cell is the mesangial cell. And this is the mesangial matrix. Okay, this is a normal histology. Now what happened in this case? This is the enlarged view of the glomerular basement membrane, this structure, enlarged view. Here this mesangial cell, it proliferates, and this mesangial cell tend to enter the basement membrane like this, and this gives rise to tram tract appearance. So in this case, there is hypercellularity is there. And there is mesangial proliferation is there. Right? So that lead to thickening of the basement membrane, but this is due to tram tract appearance. In addition, is the immune mediated thing I told you. The antigen antibody deposition occurs. In type 1, there is subendothelial deposition. In type 1, subendothelial deposition. Subendothelial means between the endothelium and the basement membrane, right? But in type 2 it is usually intramembranous, in the membrane itself. But one more thing, in type 2, this mesangial proliferation may or may not be there. Okay, but deposition occur in the intramembranous. So regarding all this, I'll be talking to you in a couple of minutes. So we understood that tram tract appearance, hypercellularity, and proliferative type of glomerulonephritis is the feature in MPG. Well, so in type 1, let's talk more about type 1. It's also known as lobular glomerulonephritis. Okay, this mesangial proliferation, I told you, and that gives rise to tram tract appearance. Hypercellular glomerular, this increase infiltration of the leukocyte, increase in the mesangial matrix, and endocapillary proliferation is there. This you can see beautifully in these photographs also. Well, this classically diffuse thickening of the basement membrane and mesangial interposition, so-called tram tract or replication of the GBM is there in these cases. And of course, there is deposition of subendothelial deposition of antigen antibody complex occur. What are the causes for type 1? Type 1 is something very interesting to talk about, is usually secondary. Okay, and one more thing very interesting to talk about, type 1, it accounts for about 15 to 20% cases of nephrotic syndrome in adults after the primary disease I'm talking about. And it lead to classical complement pathway. This you should remember, classical complement pathway activation. Now, idiopathic form is rare. Till now, whatever we have studied in the previous lectures, the glomerular disease part 1, part 2, part 3, most in all the cases it was primary was more common, much more common. Secondary were rare, but here it is reverse. Secondary is more common, primary is uncommon. So causes secondary are like immune disease like SLE. Remember, SLE can lead to membranous also. Mixed cryoglobulinemia, this is the one typical USMLE question which is seen in hepatitis C. It's a golden line to remember. If you are getting a case of hepatitis C with mixed cryoglobulinemia with nephrotic syndrome, you can must 99% you are dealing with membranoproliferative glomerulonephritis. It can occur in Sjogren's syndrome, chronic infection like endocarditis, HIV, hepatitis B and C, and it can occur in certain cancer like melanoma also. Now type 2, this is also known as dense deposit disease. Also known as, they write in short as triple D. Dense deposit disease. Many authorities, they say it is entirely a different entity, but still when they are teaching, they take this as a part of type 2 MPGN. Now it resembles like type 1, but as I told you, tech appearance may or may not be there, and deposition occur is intramembrane. This is the most important point you got to remember. And inactivation is alternate complement pathway. Point to be noted that in the previous one, type 1, it was classical pathway. Here is the alternate pathway activation is there. Okay. And it accounts for about 50, again, it accounts for 15 to 20% of the nephrotic syndrome. Now what happened? As I told you, it's an autoimmune disease in which IgG autoantibodies, so-called C3 nephritic factor, it binds to C3 convertase. And this becomes C3 resistant to inactivation. Okay, what I can say, C3, it is inactivated. Inactivated via C3 convertase. This is normal, but here these autoantibody, they bind to this enzyme. With the result, C3 inactivation will not be done. With the result, more this C3 will be there, and that is going to get deposited in the site, intramembranous. And once it gets deposited in the intramembranous, circulating level is reduced. This is the basic mechanism why C3, despite having high production, why it level get reduced. And in immunofluorescence, since there is only a deposition of complement, so when you do immunofluorescence, you only see C3, is no antigen antibody complex is not there. And I told you tech appearance is usually not seen. So now cause is idiopathic, or it may be C3 nephritic factor associated, but the most commonly USMLE question is lipodystrophy. Lipodystrophy. Whenever you are talking about lipodystrophy, that means you are dealing about type 2 MPGN. So let me give a summary of beautiful summary of what I have discussed so far. So in MPGN, there can be immunoglobulin or C3 deposit that we see in type 1, and there can be only C3 deposition that we see in type 2. Okay. And so immunoglobulin positive, complement positive MPGN, but I told you immunoglobulin negative, but complement positive, right? So this can be due to immune complex, due to infection, monoclonal gammopathy. Sometimes this can be caused by multiple myeloma or autoimmune, and this is due to alteration in the complement pathway, and this is what due to alternate pathway. Alternate pathway and the classical pathway. Now type 3, again immune complex mediated, that's the antigen antibody is there. It's again type 1, but it is very less in number. That's why at times this is not a very important thing they talk about. Again, there is IgG and C3 deposition. Tram track appearance is there. And IgG autoantibody, again the terminal component of complement is found in 70% of the patient. Subepithelial deposits are seen. In this case, we are getting subepithelial deposition. That means between the epithelium and the basement membrane. This is seen in type 3. In type 2, it was in the basement membrane, intramembranous. And in type 1, it was between endothelium and basement membrane. So what I said was, this was in type 1 is subendothelial, endothelial deposition. It is intramembranous deposition. In type 1, type 3 is subepithelial deposition. So site of deposition is different. It is only complement here antigen antibody immune complex deposition occurs in these two. Right? So a summary, lovely summary of the theme, serum complement profile in various type of MPGN. Type 1, I told you complement pathway is activated. C3 is reduced. C4 is reduced. C3 may be decreased more than C4 at diagnosis, decreases further, and at time it may become normal, but by and large it is usually remains low. C3 nephrotic factor can be detected in some patients. Terminal complement nephrotic factor is detected in 20% of the patients. Let us see what happened in type 2. Here alternate pathway is activated and C3 is reduced, C4 is normal. And for normal, C3 nephrotic factor can be detected in 80% cases. And in the type 1, it was only some cases. Terminal complement nephrotic factor can rarely be detected. Type 3, C3 is reduced, C4 is usually normal. And terminal complement nephrotic factor can be detected in 70% of the cases. Okay, I hope things are quite clear to you regarding type 1, type 2, type 3. The clinical features, they usually come to microscopic hematuria. Hypertension can be there. Proteinuria can be in the nephritic or nephrotic syndrome. So how to investigate this case? Complete blood count. Serology testing is essential, especially for SLE, hepatitis B and C, cryoglobulinemia, because they are the usual secondary causes. And remember, out of type 1, type 2, type 3, 80% cases are type 1, which is always secondary. So that's why in case of type 2 MPGN, serology should be done. Complement level is reduced as discussed previously. Prognosis, poor prognosis, 50% of the cases may develop renal failure in next 5 to 10 years. Treatment is steroid, we can, but not very effective. We can use ACI to reduce the proteinuria, or we can use some other immunosuppressive drugs. A quick recap of the last minute revision point. Type 1 complement pathway is involved, and it's most commonly secondary due to systemic immune complex, chronic infection, or some cancers. Type 1 tram track appearance, subendothelial deposition, lobular glomerulonephritis. Type 2 dense deposit disease is complement mediated. There is no anti-antibody. Idiopathic C3 nephrotic factor associated or partial lipodystrophy, very, very important. Type 3 is subepithelial deposition. Non-static proteinuria and hypertension and hematuria, we get it. So now let's discuss the question. So in this question, the most likely diagnosis is MPGN. The correct answer is membranous proliferative glomerulonephritis. The key word are 22-year-old lady, generalized anasarca, hypertension, proteinuria. It is in the nephritic range. Nephritic range. It can be nephrotic, it could be in the nephritic range. Hematuria, complement level. This is the most important thing. Once in a case of glomerular disease, especially having this type of picture where we are thinking of nephrotic syndrome type of picture, complement level reduced, you should always think about MPGN and positive for anti-hep. This, if hepatitis C is there, then by and large it's always MPG. Now stop the video. I have a question for you. I told you in type 3 in MPGN complement level reduce, it's a glomerular disease. Tell me any other glomerular disease. Remember, primary, I'm talking about primary pathology, where glomeruli are involved but complement level is reduced. What is that condition? Stop the video, write down the answer. Well, I'm sure you must have written the answer by now. The answer is in post-infectious glomerulonephritis. The typical prototype is post-streptococcal glomerulonephritis. Complement level is reduced in post-streptococcal. Okay. Now, let's discuss the other option. Now, in this case, something very interestingly, we are talking about hepatitis C. Both option B and C are possible. But B is a better answer. The reason being, patient have got hepatitis C is strongly associated with cryoglobulinemia and complement level is not reduced in membranous. I told you membranous can be caused by hepatitis B and C. Membranoproliferative can be caused by B and C, but complement level is reduced only in MPGN, not in membranous. That's why that's a better answer. Post-streptococcal, focal and IgA, they are not associated with hepatitis C. The only thing here, complement level is reduced. But in these two, the complement level is normal, so they are ruled out. So, golden line to remember. Hepatitis C, cryoglobulinemia, patient coming with nephrotic or nephritic range proteinuria, hematuria, hypertension, low complement level, tram tract appearance is MPGN. Thank you very much for watching this video.